One thing I would stress though, on top of the airway management and mechanical ventilation that will be provided to a patient with ARDS, the therapy will also be specific to the cause. Remember, there was table 32-4, all those risk factors leading to acute lung injury, which leads to ARDS. The treatments will be specific to those, but since most of those cases result in sepsis, and then sepsis in turn is what will trigger the systemic inflammation that will cause the increased capillary membrane permeability, or we call it capillary leak syndrome. That's why antibiotics is mentioned here, because most of those conditions start with sepsis. And because of that, as far as fluids go, if you read this, thank you for reading, Miss Absalon.
Research shows that patients with ARDS who receive conservative fluid therapy have improved lung function and a shorter duration of a mechanical ventilation and ICU length of stay compared with those who receive more liberal fluid therapy. Conservative fluid therapy involves infusing smaller amounts of IV fluid and using diuretics to maintain fluid balance, whereas liberal fluid therapy often results in an increasingly positive fluid balance and more edema.
Thank you. If you think about it, if the patient is still in that state of increased capillary membrane permeability, every drop of IV fluids that you infuse into this patient will end up where?
In the alveoli.
Very good. That's exactly what's going to happen. So this is the reason why you have to be conservative with fluid therapy. We can't not give the patient fluids either, because they need hydration, right? Although this patient will be given enteral feeding, which again will be discussed under mechanical ventilation. So you're damned if you do, but you're more damned also if you don't. You see what I mean? So this adds to the complexity of treating ARDS. It's extremely hard, and this is just one condition. DIC will also usually affect these patients. So on top of the ARDS that you're managing, the sepsis that started all this will also predispose the patient to disseminated intravascular coagulation. So that's another thing you have to deal with on top of this. Good thing on this chapter, this is all we're talking about, right? But in clinical, since it's in DIC is in another chapter, that's the only reason we're not talking about it here. But this patient will also develop DIC on top of ARDS. In fact, ARDS and DIC kind of go together. So a patient with burns, for instance, or sepsis can develop both ARDS and DIC at the same time. All right, let's start with airway management. So we tried our best in respiratory failure. We gave oxygen non-invasively. We did up to the last resort is, of course, intubation. So before that, we tried BiPAP, Cpap, and then still we couldn't provide the patient's oxygenation needs. So now we're at our wit's end. So we resort to intubating the patient. We're not the ones intubating, but you're the one initiating it. So you're the one starting the call. So you call rapid response, telling them, this is my patient. I think he should be intubated at this point. And then they come in, they agree with you. So now either the physician or the respiratory therapist, anesthesiologist, whoever does the intubation. The current best practice is called rapid sequence intubation. So they can do it within less than a minute to maybe 3 minutes tops. They do so with sedating the patient. So they give rocuronium IV to sedate the patient and to relax and paralyze the patient. So you have a very non-traumatic intubation. Because if the patient's awake, even if how weak they are, they will fight the insertion of the tube. I mean, imagine somebody putting an airway, a plastic tube down your throat. Of course, you're gonna fight that. Okay. Plus, you have the patient here is very confused because of the hypoxemia, so they're not thinking right. So all they're thinking is, here's somebody trying to kill me, right? So they will be, they can be violent. So a peaceful way is rapid sequence intubation. Patient gets the rock, and then they open the airway with a laryngoscope, insert the tube. We're done in less than a minute. So let's start with who gets intubated. So we had the examples already. We had respiratory failure, we have ARDS, or anyone else who are unable to protect their airway. Here are some of the reasons here. So someone who needs an airway, obviously patients who cannot remove their own secretions, that means they cannot protect their airway. So that means they're unconscious or really have a swallowing impairment, say a stroke patient, for instance, or anyone who has a condition wherein they cannot meet their oxygenation needs by spontaneous breath, so they have to be intubated. All right, so ET tubes have varying lengths and sizes depending. We have pediatrics, we have adults. So the objective is to put this airway right here. So in order to do that, because now the patients, because without the airway, you can't really ventilate the patient properly. Plus you can't protect the airway from aspiration. So we need a plastic airway in there. And in order to prevent leaking of air, as well as to prevent, let me enlarge this. Okay, you can see the picture, right?
Yes.
Okay, let's do. All right, so this is our cuff. So upon insertion, of course, the cuff is not inflated yet, so this will be deflated. So that will facilitate insertion. I'll tell you later how we know how far to put it in. As soon as it's put in, the patient's, the ET cuff will be inflated. So the purpose here is to prevent secretions, because secretions will pool here and here. Okay, so those are saliva and maybe some mucus. And they're not clean, right? We're not supposed to put any into the lungs. So the cuff has to be inflated. The cuff inflation should be just right. The cuff inflation should be, I'll go back to chapter 28. Sorry, I forgot the page.
What are you trying to look for?
Okay, I'm here. Go to page 539. So this is now the cuff, right? So it's the same, whether it's an ET tube or tracheostomy. So our purpose again is to seal the airway. That way you have no leaks. So all the breaths going in and going out must be via the ET tube. So when you give a breath via the ventilator, it goes into the tube, into the lungs, and when the patient exhales, it will also exhale through the tube. Now, to seal the cuff, to inflate the cuff, the pressure must be between, right here, if page 539. So to reduce tracheal damage, because remember the tissue, the trachea also has blood supply. So if you inflate the cuff too much, that will now compress the vessels on the trachea, leading to ischemia and then tracheal necrosis. So the only acceptable, regardless of the patient's, adult patient's weight or height, is the pressure must be between 14 and 20 millimeters of mercury, or 20 and 30 centimeters of water, whichever one, because we don't know how wide your trachea is, but we do know that based on evidence, the safe cuff inflation pressures are only between 14 and 20 millimeters of mercury, or 20 and 30 centimeters of water. After inflating that, we will now have a good seal, and then we have to attach it to this manometer right here. So this is like a tire gauge monitor. So you just simply attach the pilot balloon. This is here is the inflation, cuff inflation port, and this little tube, this little balloon here is called the pilot balloon. So if there's air in the cuff, meaning if the cuff is inflated, the pilot balloon is also inflated. If this is flat, that means the cuff is also flat. So all it does is really tell you that there's air in the cuff, but it won't tell you how much air is in there. So to tell you, you have to attach it to a manometer, and again, what should be the range?
12 to 40.
14 and 20 centimeters of mercury, or 20 to 30 centimeters of water. What page were we at earlier?
629.
Thank you, boss. Okay, so it tells you right here. So the pilot balloon is a one-way valve, prevents air from escaping. So it just tells you that the cuff is inflated, but does not show how much or how little air is present in there. So it's going to be like this. So you call rapid response, they come in, they give rocuronium IV, patient sedated, they put the laryngoscope and then insert the tube inside it, and then take out the laryngoscope, and then how do they inflate it? Okay, so whoever inflated it will take out their stethoscope and then put the stethoscope over the neck. So this is somebody's stethoscope. They listen for air here. So they'll attach a syringe to this pilot balloon, empty syringe, because we only inflate it with air. So we slowly inflate it. Of course, if somebody is bagging this, so there will be a bag valve mask here. Okay, so somebody's bagging this patient manually. So the patient starts breathing. So at this point, the cuff is still deflated. So therefore, whoever listens to this will hear a leak. So he'll hear air here going, very violent air going in and out because somebody's bagging the patient. So he'll keep inflating the balloon. So he'll slowly inject this until the leak disappears. So when the leaking sound disappears, that means we've already achieved the seal. So that's what it means here by minimal leak technique. So down here, So the cuff at the distal end is inflated after placement to create a seal between the trachea and the cuff. The seal ensures that the delivery of tidal volume, or tidal volume again, is the air delivered with each breath. And then this is the technique by which we inflate it. So we use a minimal leak technique. So we only inflate it to an adequate sealing volume. And then right after that, we take out the syringe and then we put the manometer here. So remember that manometer, that little thing that looks like a tire pressure gauge monitor. So we connect the pilot balloon to that, and then we pull the trigger to see how much pressure. As long as, again, the pressure, what should the normal pressure be?
14 to
14
20.
to 20,
Millimeters of mercury, or?
20 to 30 centimeters of water.
All right, very good. So that's the inflation. All right, but we're not done yet. So that is only the inflation. Now we have to know how far is the tube. Now the tube, when whoever inserts it, they will meet resistance. When they insert it, they will hit the carina. The carina is that part of the mainstem bronchus where they bifurcate and splits into the right and the left mainstem bronchi. That, if you imagine it to your body, that will be your crotch. Can you picture that? So if you're standing and then the right mainstem bronchus and your left mainstem bronchus are your right and left leg, the carina is your crotch. Does that make sense? Can you picture that?
Yes.
Okay, so the carina, you'll hit the carina. So when the person inserting it, he will meet resistance. He or she will meet resistance. And then when they do, they'll pull it back a little bit, because that means they already hit the carina. So they'll pull it back and then do the cuff inflation. And then we need an x-ray. So, but the x-ray will take several minutes before we can get the results. So therefore, we need to know that we are in the right tube, because we may have intubated the patient in the esophagus. All right, so we need to know, are we in the airway now? We don't need to wait for the x-ray. So what we can do is this one first. So there are two ways to do it. The most accurate way, of course, is the x-ray. However, it's not only x-ray. It has to be end-tidal CO2 monitor plus the x-ray. Because on the x-ray, remember the x-ray is only one plate. It's a flat plate x-ray. We did not take the x-ray from the side. So when we take an x-ray, the tube will show up, but we don't know, is that tube in the esophagus or is that in the trachea? There's no way to know. All it will tell you is where is the tip of the tube. So that's where you need the x-ray to see where is the tip of the tube. However, in order to know, is the ET tube in the trachea, we need to check for the presence of CO2. So this is a monitor. It looks like a pulse ox device, or the biggest one, of course, looks like the size of a Dynamap, those blood pressure machines you have on the floor. Either way, it will tell you either change color or give you an actual number of the CO2 level. So you put it at the tip, you put the sensor at the tip of the ET tube. If it detects CO2 and the CO2 is either normal or high, where is the tube?
In the trachea.
It's in the trachea. If it's low, it can't be in the trachea. It must be in the esophagus, because we normally don't have high carbon dioxide in the stomach. Does that make sense?
Yeah.
So you need both, okay? It can't be one or the other. There has to be both. After you check the end-tidal CO2, yes, you are in the trachea. That's 100% guarantee. However, you won't know where the tip is. The tip must be verified by X-ray, and the placement must be 2 centimeters above the carina. which is almost an inch. Where is that? Let me see. Right here. So it must rest 2 centimeters above the carina. We don't want it too deep because based on the anatomy, the right mainstem bronchus is straighter, whereas the left mainstem bronchus is more crooked or more angled toward the to the left. It's more of a what angle is that? Obtuse angle. Whereas the right mainstem bronchus is almost straight. So if you um, don't verify by X-ray, your tube might be in the right mainstem bronchus, which is a problem because remember that tidal volume, the breath that we measured, is measured for both lungs. So that means if it's on the right mainstem bronchus, if the tube is way too deep, it's too far into the airway, it will only ventilate the right lung, which can cause fracture or even rupture the lung because now you're putting the air that's supposed to be for both lungs into only one lung. Is all of these making sense so far? Any question? Okay. The choice between endotracheal versus a tracheostomy depends on the length of time. So if a patient only requires intubation, mechanical ventilation for about 10 to 14 days, we can stick with the endotracheal tube. Beyond this period, you have to switch to, and this is a rule, you can't violate this, you have to switch to a tracheostomy because this one will have more complications because remember, if you have a tube in your mouth, you can't talk, you can't eat, and you have to be sedated most of the time. Whereas if you have a tracheostomy, we can take you off sedation, you can eat, you can talk because we do have fenestrated tracheostomy tube, so you're able to talk, you can now ambulate, right? So your healing will be faster if you have a tracheostomy. So therefore, if you need ventilatory support for longer than 2 weeks, then you're better off with a tracheostomy. It's temporary anyway, so don't worry, it's not going to be permanent. You won't have a stoma. Okay, they'll just put a they'll just create one incision, vertical incision, and put the tube there. So the only thing keeping the incision open is the tracheostomy tube. So the moment we take it out, it starts sealing right away, and then you're okay. So that's the airway. All right, so we sedated the patient, we inserted the tube, we inflated the cuff, we took an X-ray, we took the Untitled CO2 detector, so we verified placement of the tube, we achieved a proper seal of the airway. We have a seal because we inflated the cuff, we have placement. Now we need to maintain that. In order to see whether or not we have accidentally pushed the tube down or pulled it out unintentionally, we need to document the markings. There are, if you notice, there are numbers here on the lines of the ET tube. So this is what these are the tip, and these are, of course, the cuff. Okay, so this is inside the airway. This is what's at the tip. So you check which marking is at the teeth. So the patient, we use the teeth, or if the patient doesn't have teeth, then it'll be the lip. Okay? Or if it's a nasotracheal, so if it's in the nose, then of course at the nares. Okay, so we need to document what number is there. That way, part of your assessment, if you see the ET tube was either pushed down, that means it may be in the, most likely it's in the right mainstem bronchus because of the anatomy. Or if it's pulled out, then it's too far. We may have it over here, in which case the air could be entering the esophagus already. Right? It really depends how far is the tube pushed out or pushed in. So we need, either way, we need to document where was it originally, right? So that will keep it in place. So we did intubate, we verified the placement of the tube, and okay, next thing is to stabilize it. So to keep it from moving, we will have, we'll use a tube holder. Most facilities now use Velcro. We don't use tape because tape, of course, this patient will drool, they will sweat during suctioning and bathing. The tape gets wet, so not very good. It will loosen, and then you don't have a good tube securement device. So we use the Velcro. It's commercially available. It's easy to put on. Just wrap it around the patient's mouth and at the back of the head, and it's a caveman can do it, right? It tells you exactly how to put it on. Or some doctors prefer a bite block to prevent the patient from biting the tube, which is handy because anytime you're not there and the patient, let's say, in your busyness, you forgot to hang a new bag of sedative, for instance, the propofol was empty, and the patient's awake, and now they're confused, they're gonna bite that tube. And of course, that will trigger your high pressure alarm, so better to put a bite block. All right, so we secure the tube, we verify placement, and we ensured proper airway seal. All right, so we're good to go. So now we're going to take care of the, attach the patient to a ventilator now. Now this whole time we were, of course, somebody was bagging the patient, okay, manually giving breaths using the ambu bag until we can attach the patient to the ventilator. A few more details here. I think I mentioned this earlier. So when we're messing with this patient, part of overall care, we can accidentally dislodge the airway. So make sure your markings are properly documented. And anytime you suspect that the tube may be displaced, get your ET CO2 detector. We call that a capnographer. Capnometry, sorry, capnometry. The equipment is capnometer. All right. These also will cause movement of the tube. So take care. So these are all part of when you're turning the patient. Okay, patient usually is sedated, so there will be incontinence. We have to change them. You bathe them. Time to turn as part of pressure ulcer prevention. So we move this patient a lot. So therefore, you have to do these things more often. So it's not one time. I mean, I'm not saying this means you don't only check and verify placement once. Of course, we're not going to get X-ray all the time because that's the whole point of marking the position at the teeth or at the lip. That way, you don't have to require chest X-ray all the time. And then you do have the capnometer to check for the CO2 level. So as long as it's good, the numbers are either normal or high, then it's in the trachea. We don't really physically restrain the patient, but we can if needed. But if you have good sedation, I mean, there's really no need to restrain the patient. It may fall under chemical restraint, but technically we're safe. We're not really chemically restraining the patient. It's more for patient comfort. So when you sedate them, actually it lessens the oxygen demand because you're relaxing the patient, so they're not fighting the ventilator. So your oxygenation is optimal. Because the more this patient moves, then the more worked up they get, the more oxygen demand. So you don't have very good ventilation. Okay, so we need adequate sedation. So here's the reference to the chemical restraint, and for patient safety also. We'll do the complications later under mechanical ventilation. So these pneumothorax, these things are mentioned later under mechanical ventilation. Interrupt me anytime, okay? So here we are now. Any question on the airway management? Now, all I'm discussing here is for the NCLEX, all right? I know most of you who may be working in the hospital, nurses are not doing these things, but these are actually nursing responsibilities. Okay, they do not. Did you ever see here that there is the respiratory therapist? This whole time we were talking about it?
No.
No. Okay, so you may ask, well, why the hell are we checking placement? When we're not the one intubating the patient. Well, the answer is the respiratory therapist won't be there the whole time. And besides, how many respiratory therapists do you see on the floor? Do you have one for dedicated for each floor?
No.
No. Sometimes they're, especially at night shift, the poor respiratory therapists have maybe 4 units to cover. And that's a lot of nebulizer treatments to give. In the ICU, though, they may be 1, or sometimes if they're lucky, they get 2. And worse is they cover the ICU as well as the ER at the same time. So that's a pretty bad assignment. So while the RT is not there, that's why these are the nursing responsibilities. Because we're way capable, you know, we're just as capable, I should say that, as the respiratory therapist. All right, so let's go to mechanical ventilation. I'm not saying that you'll be able to go and be in charge of a ventilator after this lesson, all right? All these are minimum necessary for us to answer questions on the NCLEX. Let's start with best practice. 32.9, for every patient on a mechanical ventilator, these are your responsibilities. Assessment. So just like any other respiratory patient, you assess them. Lung sounds, vital signs, oxygen saturation. You look for physical signs also of hypoxia. So you look at a patient's color, the chest expansion, and of course the placement and markings on your ET tube or your tracheostomy tube or your nasotracheal tube. Now remember, these patients, most of these patients are sedated. So can they show you, are they conscious enough to show you, confusion and all that?
No.
No. So your main accurate assessment will be via ABGs. We draw ABGs. I know most in practice is via arterial stick done by a respiratory therapist. However, if these patients are intubated, they most likely have an arterial line. So arterial line, you can draw blood there. That's arterial blood. So you can send that for ABG. Head of the bed should be 30. For the reason is this will be enough to prevent aspiration as well as ventilator-associated pneumonia, while at the same time decreasing the risk for pressure ulcers. Because the higher you go, then the higher the shear, the higher the the shearing forces on the sacrum, promoting pressure ulcer development.
Question. I have a question right there. Sorry to interrupt. If we see 30 in an exam, will that be considered wrong, or should we take like 31 because it says more than 30?
No, 30 is fine.
Okay.
Okay, at least every 8 hours, you should check if your ventilator settings are fine. One thing to understand is your patient needs isn't the same the whole duration. patient's needs change. That's why we monitor ABGs routinely to see is our mode and setting still appropriate for the patient. Because most of the time we expect the patient to get worse or get better. Do we want them to be better or worse?
Better.
Of course, and that's
Better.
what, yeah, and then that's what we expect, right? So we expect them to get better. So will their oxygenation needs remain the same?
No.
No. So it's not a matter of set it and forget it. It's set it and monitor it constantly. So we need to see, does the patient still need to be intubated? All right, so we constantly draw ABGs, we constantly examine the patient, we monitor the patient. Check sure your alarms are set. Anyway, it won't let you program it, and it won't keep quiet until you set these on. So I don't know why they put this here, because you can't really, there's no option to not set it. And unlike before, where in older ventilators we can mute it, nowadays you can mute it only for about 2 minutes to allow you for, alarm-free sessions when you're suctioning the patient. Before, we didn't have that safety feature, at least when I was still in the Philippines. It was, we had the option, because it was very annoying for alarms, so we had the option to mute it, and it was so nice. The whole shift is quiet. But then patients started dying because the alarm was going off and we couldn't hear it. Okay, this part here, empty ventilator tubings when moisture collects. That, let me illustrate. So this is when, let's say this is basam, okay? And basam is on this is the vent.
We're not seeing what you're drawing.
Oh, sorry, once. Okay, so this is the vent. And these are the circuits. This is 6 feet long. You can't really cut it. So the patient's ET tube, and then this is the circuit. And then you have the oxygen right behind here somewhere. So that would be your oxygen source. That's the second circuit. Okay, so you have a circuit from the oxygen source, another circuit from the vent. All right, so you see this loop right here? Since the oxygen is humidified, there will be moisture here. So this will collect over several hours because of the humidification, plus the air is also warm. As it enters the vent, the air becomes warm. So it doesn't trigger coughing, because if it's dry and cold, that will trigger the cough reflex. So the air going into the patient, each breath is warm and moist. So eventually there will be some condensation here. This is what this thing is referring to. When moisture collects, never empty it back into the cascade, meaning don't put it back here. Or worse, don't put it into the patient, because the patient will aspirate. So what you do is just disconnect it for 1 to 2 seconds and then drain this into a whatever container. Okay, so just get rid of that and then put it back. All right, so do not empty it back here. You may say, oh, that's coming from there, that's clean. No, we don't know how long that thing's been in there. And the whole thing isn't sterile, right? This is just a clean setup. So there could be bacteria there already. Plus, we don't really change the circuits every day. Okay, there's no routine changing of the circuit tubings. They're good for maybe a few days, so we don't. What happened? Okay, so that's that part. Yes, we keep the air humidified. Yeah, this is ensuring proper cuff inflation, and you listen for lung sounds and suctioning. Okay, before we go any further, let's do suctioning. Now, this bullet says check every 2 hours if they need to suction. How often do we suction?
As needed.
Only as needed, right? This doesn't mean suction every 2 hours. There's no routine suctioning. We suction if needed. Now, what are those indications of suctioning? 6:30, let's go back to 5:39, I think it was.
Yeah.
All right, so when do we suction? All right, here. Chart 28-2, page 541. This is suctioning the airway. So let's look at the when do we suction? These are your indications. There's some indications also listed in chapter 32, but there are some here. So I'm just telling you because I might get it from here because there's some tiny bits of difference. So these are the indications that the patient needs to be suctioned. So audible or noisy secretions, you hear crackles or wheezes, the patient gets restless, and then when you check the oxygen saturation, it's low. Or you can see, you can visibly see secretions at the airway. Okay, you can see it at the tube or already entering the circuit, for instance. So that's your, and then I leave you responsible for reading chart 28-2, especially the part where how long you pre-oxygenate and how you suction, you insert the catheter until, how deep do you put the catheter in?
Until resistance is met.
Okay, until it comes out of the rectum.
No.
Okay, so if you meet resistance, then you already hit the carina. So pull back a little bit and then apply suction. So here, we draw the catheter until when you meet resistance, we draw 1 to 2 centimeters and then start applying suction. It is now continuous. Okay, so this is the 9th edition. I've seen the 10th edition. It also says continuous. All right, because I know in skills lab, we may have been taught intermittent, right?
Mm-hmm.
You remember? Yeah. So
Yep.
the ADIS is, this one clearly says continuous suction.
Okay.
This hasn't changed. We never suction longer than 10 to 15 seconds. And then right after that, before you rinse the catheter, you hyperoxygenate first. So you replace the oxygen before you rinse that catheter. And then repeat up to 3 total passes. Now, you have to wait, therefore, for at least 1 minute before you start another pass. Right? Let the patient recover first. Either wait there or look at the patient. The patient's color will go back to normal. Of course, you're triggering hypoxia, right? When you're inserting the catheter, so the patient turns purple, blue, and then after you stop suctioning, you put the oxygen back on, and then they'll recover. Color will come back, and then you can do it again. And suction mouth, there's no limit to how often you suction the mouth. Although we do have a bundle later with mechanical ventilation. No, it's under preventing ventilator-associated pneumonia. So VAP bundle will give us another chart like this. Okay, so this is chart 28-2. So let's go back to what page, Miss Huertas?
6:30.
6. 39?
30.
6:30.
Mhm.
All right, so we were at the best practice chart, right? I skipped this. Please read this critical rescue. Okay, these are related to the airway. So this is the acronym DO. Okay, so we stopped at suction. Where were we? Okay, here. So we stopped at suction. So you referred to chart 28-2. The tube must also be moved. It shouldn't stay in one part of the mouth. So you can put it on the center, the left, or the right side. So just adjust your tube holder as you move it around. Because it's a hard plastic. It can cause pressure ulcers on the mucous membrane. The mouth care must be done every 2 hours. Let me introduce you to the Q Care kits. So you've probably seen these in clinical. All right. So these are one kit. So there are 1, 2, 3, 4. 4 because they want you to do it every 2 hours. So therefore, 4 will give you 8 hours, right? And the managers count these things. So the manager knows, your nurse manager knows how many patients are on the vent in any given day. And she knows part of her budget is purchasing these things. So when she purchases them and then it doesn't jive with how many did she purchase and how much were used with the ventilator days total for the week or for the month, you guys are in trouble. So that means, are you doing your mouth care as you're supposed to?
No.
No. Some nurses are smart. They just get them and then throw them in the trash. Really, really bad example, right? Really bad practice. That's violating your oath, the nurse's pledge. You have these, please use them. Okay, it's a no-brainer. All you do, because you have to turn the patient anyway. So every 2 hours when you're in there turning the patient, use the kit. So you grab one and then perform mouth care. One of them is a toothbrush. So you only have one toothbrush per kit. That means you brush your teeth, not your teeth. You brush your patient's teeth once every 8 hours, but you do mouth care every 2. The mouth care is just using a tooth tip. It's not very clear, but these are sticks, and at the end there's a sponge, and these are the solutions. Okay, so you just break them up, soak the tooth tip, and then attach this thing to the suction tubing, and then put it in the corner of the mouth. How this works is just like when you're at the dentist, and then the dentist puts the suction at the corner of your mouth while they're doing the cleaning, right? When they spray all that water. Can you picture what I'm saying?
Yeah.
Yeah, so the same thing. So you put this in the mouth the whole time so that it suctions the secretions. We don't want this liquid going to the patient's throat. So as you're doing mouth care, you're suctioning does this trigger, remember, it stimulates saliva production when you're messing with the mouth. All right. I'm sharing it by experience. I mean, I've gotten in trouble for not using the Q Care kit. I mean, you don't lose your job, but it reflects badly on you. It's embarrassing. You're a nurse, and then you're not doing what you're supposed to do. And then your manager will ask you, "Why did I hire you again?" Just very smart ass comments like that. "Why did I hire you?" And then that's what do you call that? Um, I don't know. Either way, it's embarrassing. So, okay, and then turn the patient every 2. All right, regarding this, I'll discuss this settings later. We'll discuss the settings in the mode. These are the common complications resulting from mechanical ventilation. Infection is pneumonia. Barotrauma is the pressure. Baro means pressure, so barotrauma. Remember, the patient's lung compliance here changes. They could get better, they could get worse. So therefore, the settings, the pressure settings, the amount of tidal volume will have to change with it. I'll explain all that again later. Because again, the patient's lung compliance changes. Compliance, we're referring to the stiffness of the lungs. So the lungs can get softer or can get stiffer. Of course, stiffness of the lungs, it gets stiffer, that means it's getting worse. Getting softer, that means it's getting better. The compliance is better. And because of the increased pressure, plus we have positive expiratory end pressure, so every ventilated patient will have increased intrathoracic pressure. Now remember, the heart is also in the same thoracic cavity. So if you're ventilating the lungs, of course, that will compress the heart, correct? So if you're not monitoring that, the patient's cardiac output could drop here because of the changes in the patient's lung compliance and the pressure, which may lead to increased compression of the heart. So therefore, less venous return, less cardiac output. As far as positioning the patient, with ARDS, the current best practice is to put them prone. So we put the patient on their belly. I'll show you later how to do that. Otherwise, when we're turning them side to side, we always favor the good lung down. The rationale for this is to allow the defective lung, the bad lung, larger or easier expansion. Okay, and also to promote lung drainage from that bad lung. If you read literature, because there are many now coming out saying bad lung down, our textbooks still say good lung down, so we follow this, all right? I'll explain weaning later. Explain all procedures to the patient, so don't assume that they're sedated, that they can't hear you, all right? They can hear, they just can't talk back. So every time you're cleaning them, be conscious, because sometimes we forget that the patient is there. I'm guilty of the same thing. You know, we talk about things during patient care. We talk about other people, or sometimes the patient themselves, or we use the time to bitch about, you know, the unit and all that stuff. Be conscious, okay? The patient can hear. Yeah, that's for your own good, okay? But plus, we really shouldn't be doing that. Okay? We don't act like the patient wasn't there. Okay, so you act like the patient's conscious, so you explain everything. You know, you say sorry when you think you're, let's say when during cleaning, I'm sorry if this is painful, all right? So I'm almost done. So constantly talk to the patient. And if they're off sedation, you provide a method of communication because they can't talk, the AT tube's in the way. So they can use a pen and paper. We have communication boards with pictures of commonly used, you know, needs. Let's say bathroom, or I'm hungry. I want to use the, you know, a TV remote, for instance, all that, or a Ouija board. Okay, you provide them with a Ouija board. So these are your drugs routine. We have fentanyl or morphine hanging propofol as part of routine sedation. We don't restrict visitors. In fact, we encourage. And lastly, because we're almost, you know what, we still have a few minutes. Please remember that the ventilator does not cure the underlying disorder. So it does not cure the respiratory failure. It does not cure ARDS. This is only ventilatory support, keeping the patient alive until we resolve the underlying cause leading to the respiratory failure. I think I can still do this part and then continue next week. Okay, let's just do 2. You know what? Let's do the settings and then we'll do the modes next week. Okay. I'm talking to myself. Are you guys with me?
Yeah.
Yes.
Yeah, listening, Professor.
All right. So let's do the settings and then we'll come back with the modes next week. Do we have a quiz next week?
No.
We don't have class next week, do we? It's July 3rd.
Oh yeah. Well, what I meant was
The following.
yeah, July 10th. Do we have a quiz?
Good question.
When is the 3rd exam?
Yeah, we have a quiz on July 24th. 10th.
July 24th is the third exam. I think.
24th?
24th, yes. July
That
24th.
means how many weeks do we have left? Yeah, 1, 2. 2 weeks after this, I still have chest trauma to do next week. Yeah, we can finish this. I mean, 2 weeks from now. All right, settings. So you have a ventilator. There are settings in there. Let's start with the tidal volume. The vent has to know how much breath do you want me to give this patient. So the formula is most hospitals use the weight, 6 to 8 mLs per kilogram of body weight. Hello? What was that? I missed that one. Was that a question or comment? Hello?
Oh, sorry.
Oh, that wasn't for me?
No, I'm talking to myself.
All right, so let's do tidal volume. So this is the breath, the volume of air given with each breath. So this is the amount that the ventilator gives the patient. Most hospitals use the weight at 6 to 8 ml per kilogram. I have worked for a hospital which uses the height, which I think makes more sense because the weight of the patient doesn't really determine the size of the lung, does it?
No.
No, because it take for example somebody who's 4 feet 5 inches tall, and then they weigh 200 pounds. Does that mean they have a large lung?
No.
No. So for me, really, I was more toward that one hospital which I worked for where they used the height. Okay, the height was the determinant for the tidal volume, which makes sense because the taller you are, the larger your lung, right? Anyway, so most hospitals still use the weight, so it's between 6 and 8. So averages about maybe 400 mLs of air. But one thing to take note is even if the patient's tidal volume on the vent is 400 ml, let's say, doesn't mean he's gonna get 400 ml because it really depends on the patient's lung. If the compliance is lower, can you put that 400 ml in there?
No, it's gonna get less.
No, yeah, because if it's very stiff, if it's very wet, it's not gonna get very much air in there. Okay, so there on the screen of the ventilator, it will tell you what the setting, the tidal volume setting is, and then below that, right next to it, will tell you how much did the patient actually get. Okay, so based on that, you can have an idea about how good or how bad is the patient's lung compliance. So you see the setting, and then you'll see the actual right next to it. Next is the vent also needs to know how many times you want me to give this breath. Okay, usually it's between 10 and 14. The reason why it's 10, which is below normal, right? Normal is 12 to 20. The reason is the most common modes allows the patient to breathe spontaneously. So they're kind of adding this, this breaths plus the patient's breath. So that way we don't have hyperventilation. Does that make sense? Because they assume that the patient will be breathing as well. I'll explain that later next 2 weeks from now when we get to the modes. So we'll just stay with the settings tonight. So again, tidal volume is the amount of air. How much air is the patient receiving with each breath? And how many times do they get it from the ventilator? On the screen, the rate might say F, which is frequency. So it depends on the mode, the model of the ventilator. So, but all of them say VT. So this is a symbol for tidal volume. It's V and then small letter T. And then the rate could say rate or frequency. And then it has to know, you have to set FiO2. How much concentration of oxygen do you want to give this patient? Everything starts at 21, then go higher from there. We hardly use 100. This is not very beneficial. This one actually can cause possibly lung collapse. So we try to keep the FiO2 around 21, maybe 24. And if the patient goes bad, we go higher. The reason is there is oxygen toxicity. So we don't want that. So we try to keep it low, as close to normal as possible. Right now you and I are breathing 21% FiO2. I already mentioned that it is warmed, so the ventilator warms the air as it enters there from the oxygen source, and there's also a humidifier when it exits the ventilator. Peak airway pressure. So this is the height. So to illustrate this thing, if this is zero pressure, okay, so so let's say this line is zero pressure. So you'll see on the screen of the ventilator, when the patient gets a breath from the ventilator, it'll go this way. It starts from zero because it's a positive pressure ventilator, so it never goes negative. It'll go positive like this, like this. And then the next breath will be whereas the patient breath, you can see that it's a patient breath because it goes negative. It goes right here. Right before the breath, it'll go negative because imagine when you're breathing, you go like that. It goes negative, right? As the diaphragm goes down. So you get all right. So this, if you see it dip below, then that's a patient breath. Anything positive above the zero line is delivered by the ventilator. So you can literally count how many breaths did the vent give, how many spontaneous breaths did the patient make. Okay, so here at the peak is the peak inspiratory pressure. These are all, the highest point is the highest pressure. Now that PIP of course changes depending on lung compliance. That's always the determinant. So the doctor will change the setting according to the lung compliance. So the more compliant the lung, the peak inspiratory pressure.
The higher.
All right, very good. So therefore, the lower the lung compliance, the
lower the PIP.
All right, because they cannot, you can't overventilate it, right? You can't put too much pressure. You're gonna rupture that lung if you force it. So the peak inspiratory pressure depends on the lung compliance. So here's what it says here, down here. Increased secretions or the lungs or the chest wall is stiffer. Okay, so that tells you about the compliance. Okay, how hard or how easy is it to ventilate the patient's lung? We're almost done. Cpap. Cpap is not, this is not referring to the machine, okay? Cpap is a setting on the vent, meaning the vent can become a Cpap. It has a Cpap function. This is only used for weaning. When we start to wean the patient, there are many ways to wean them. One of those is to use the ventilator as a Cpap. So no need to disconnect them and then connect them to a Cpap. Okay, so you just simply turn off the vent and then turn on the Cpap function. So of course, in a CPAP doesn't provide a breath, does it?
No.
No, it only provides positive airway pressure. So if you turn on the CPAP, that means the vent function is off. The vent stops giving a breath. It will only give positive airway pressure, only pressure. So that means the patient must be breathing in order to survive on this setting. Because remember, the vent is not giving breaths anymore. You're telling the vent to function as a CPAP. So in order to do this, the patient is already, of course, we're starting to wean the patient. So therefore, sedation is taken off, or maybe very little, in order to do the weaning. You can't wean with sedation. So just like a CPAP, a regular CPAP, it keeps alveoli open during inspiration and prevents it from collapsing. So therefore, because there's continuous positive airway pressure, whether the patient's breathing or exhaling, it does not let the alveoli collapse. It can't, because you are pushing pressure on the patient's lung constantly, non-stop. Whether they inhale or exhale, there's pressure blowing in there, keeping the airways open. So as already mentioned, this is only used for weaning. You cannot put patients on a ventilator. They need the ventilator. So only if you are already off the sedation, you were getting ready to wean you, then you can be on the CPAP. This is the normal setting, 5 to 15. The other mode for weaning is called just the T-piece, meaning this is the connection between, let me draw it. So a T-piece, this T-piece here is referring to, let's say this is Basam, and this is the T-tube. The T-piece is it's literally T. Let me just draw it sideways. Okay, so it's a T-piece. This is where you connect the two circuits, one from the vent, one from the oxygen source. So here, this is the T-piece where you connect it. So you can disconnect the circuits from the vent and just allow the patient to breathe from the T-piece. That's also another weaning, meaning the patient is taking spontaneous breaths here. No CPAP, no ventilator, right? So, but they still have the airway, meaning we're just trying to give them breathing trials. So you just allow them, okay, let's see how you do. All right, so you take them off, patient breathes on their own, check ABG, is it okay? All right, and then you proceed with the weaning procedure, weaning protocol, sorry. Lastly, and then we'll call it a night, is Peep. Peep is positive and expiratory pressure. So this is dialed into the ventilator. The numbers are between 5 to 15. This is good. Anything higher than 15 is already really high. So Peep is a setting on the vent this is the purpose. It is your purpose of putting PEEP is to, just like in CPAP, wherein you don't want the lung to collapse. Another purpose is, instead of increasing the FiO2, why not just increase the pressure? All right, it's smarter. You can hear. It is important to lower the FiO2 delivered whenever possible, because prolonged use of FiO2 will actually cause toxicity. Right? So instead of increasing FiO2, why not increase the PEEP? Okay, so PEEP goes, let's go back here again. So this is 0 pressure. All right, and then let's say the patient breathes like this, or the vent gives the breath, and then it doesn't go 0 here. Unlike normal respiration, if we were breathing right now, which we are, our pressure, so when we breathe, it'll be like this. Negative, we breathe and then go back to 0. And then 5 seconds later, we breathe again, goes to 0. So this is the end expiratory pressure here. In a normal lung, this is 0. 0 pressure, no pressure. I'm not saying there's no air there. There's air, residual air, but then there's no pressure. Pressure is 0. Here on a vent, when you add the PEEP, it doesn't go 0. It will go 5, maybe 10, maybe 15. All right? So, but remember, the higher your PEEP, the greater the effect on the heart, the greater the burden on the heart. Because what happens is, this is your heart, these are your lungs. The higher your PEEP, you're keeping the lungs inflated longer. Whereas here, normally, there's no pressure. So if there's no pressure, the heart can expand normally. Okay, remember PIP? So at the peak inspiratory pressure, both lungs are actually squeezing the heart, if you think about it. So during PIP, when both lungs are inflated to capacity, they're actually squeezing the heart, squeezing the superior and the inferior vena cava. So venous return drops during PIP. Not too long, maybe 0.2 seconds. Okay, that's not too long. However, imagine here, because normally we go 0, right? That's the normal. So the heart fully recovers. However, on a ventilated patient, because now you add PEEP, the higher the PEEP, the longer the heart stays compressed. What happens to your venous return?
Decreases, diminishes,
Decreases. What happens to cardiac output?
diminish.
Decreases also.
Right, so this is one effect of PEEP. So you can't have a high PEEP. So 5 to 15 is tolerable. That pressure won't really harm cardiac output very much. But the length, though, the duration at which you apply that can matter. So usually we're happy as long as it's 5, maybe 10, that's fine. It will not have any major impact on cardiac output at all. But once we go more than 15, let's say 20, because sometimes it's necessary, especially if the compliance drops, the doctor will order to put the PEEP to 20. Always monitor your cardiac output. So monitor your blood pressure, your patient's urine output, color. So watch those when you have a patient receiving high PEEP. And that's it. Any questions before we say goodnight?
We're not gonna talk about flow rate.
We have no time, so we'll remind me to start there on July 10th, please.
Okay. Sounds good.